Do you know what your heartbeat sounds like? Ever wondered how something as seemingly small as an irregular heartbeat can change the course of someone's life? What would you do if your heart didn't beat quite the way it should? Welcome back to the Health Exchange. Here we make complex medical topics approachable and engaging. I'm Savannah Background, and alongside me is my co-host, Dr. Jamie Rutland. Today, we're tackling a condition that impacts millions worldwide, atrial fibrillation, also known as AFib. It's more than just an irregular heartbeat. This condition can raise the risk of stroke, heart failure, and other serious complications. In this episode, we'll break down the science of atrial fibrillation, explore cutting-edge therapies, and highlight what you, the patient, need to know to boost outcomes and quality of life. Joining us is someone who's a true leader in this field, Dr. Brad Sutton, an electrophysiologist and chief medical officer at Boston Scientific. So, Dr. Sutton, thank you so much for joining us today on this discussion.
Well, thanks for having me. Excited to be here.
Do you want to give us a little bit of insight about who you are and your background?
Sure. So I'm a cardiac electrophysiologist, which is a fancy way of saying I'm an electrician for the heart, and I deal primarily with diagnosing and treating abnormal heart rhythms.
And tell us a little bit about your practice.
So I was in practice. I did my training at Johns Hopkins. I spent 12 years in Baltimore training, med school, residency, fellowship, and then was in an academic practice for about a decade. And then I stopped seeing patients completely, and now I work in kind of corporate America. But the idea behind that transition now as chief medical officer is, it's a beautiful thing to touch one patient at a time in the EP lab and in clinic every day. But what we do now is, as you mentioned, try to bring innovative technologies to the world, really on a global basis, millions at a time.
Great. Well, thank you for being here.
Yeah.
So we're going to dive into a big topic and one that's close to my heart, as both of you know, which is atrial fibrillation. Atrial fibrillation, do we want to just get right into it?
I guess the major question is, earlier you said you're an electrician of the heart. So obviously the heart generates electricity. Do you want to tell us about how the heart does that and what the point is? Like, why does it do that?
Yeah, so there's what I would call kind of the normal functioning electrical system of the heart. And so it has the intrinsic ability to generate a heartbeat. And that heart rate can change based on, are you excited? Are you relaxed? Are you exercising? And so the normal system contracts kind of top to bottom. The top chamber is the atria, pump blood into the bottom chambers, the ventricles, and out to the body. And when all's working well, that's generally a nice, normal, regular rhythm. Atrial fibrillation, which is the most common arrhythmia in the world, is, think about it as electrical chaos in the top chambers of the heart. And so instead of that nice, normal contraction, if you were to open the chest and look at a fibrillating atrium, it'll look like sort of a jello mold, just sort of wiggling and not contracting blood effectively.
I like to, when I'm talking to my patients in clinic about this, just to make it really easy for them to understand, I tell my patients that it's as if you have a drummer in your heart, right? So you want your drummer to be on beat. You want your heart to be beating consistently, ba-boom, ba-boom, ba-boom. That's normal sinus rhythm. In atrial fibrillation, however, your drummer is beating chaotically. They might be going really fast. They might be going really slow. They might be missing a beat altogether. When that is occurring and the heart is not beating, effectively, the blood can't flow through the body the way that we want it to. And then our patients are coming in and they're having symptoms of fatigue, shortness of breath. They might be having palpitations, or they're at an even bigger risk of stroke.
I describe it almost the same way.
Yeah.
In the intensive care unit, I always tell my patients, and Dr. Sutton, I want you to correct me if this description is off. But often when we were learning about the heart, we'd say, okay, SA node, AV node, His-Purkinje, whatever, fire, go, right? Contract.
Right.
But I would always tell my patients, listen, it's not exactly as organized, right? The SA node isn't just in one spot. You've got a bunch of pacemaker cells that are around that general area. And as we all age, the way that I always thought about it is sometimes those tissues would deteriorate. Maybe they would stretch out a little bit, or maybe there'd be some fibrosis, something like that. And that would get in the way of these pacemaker cells functioning appropriately. And so they would fire all over the place, like your little drummer, right? And then you would have this action potential. You would have these heartbeats that are just irregular because the pacemaker cells are like, listen, there's a little bit of disorganization going on here. I don't quite know what to do. I mean, that's how I would describe it in the ICU. Is that like totally off? It's like, no,
No, I don't think it's totally off at all. And I think it gets to this idea of risk factors for atrial fibrillation. So when you talk about the heart tissue itself getting sicker, what does that? We get older, high blood pressure, heart failure, diabetes, all these things sort of interplay in a way that can predispose or make atrial fibrillation more likely. And then, of course, the longer you have AFib, the more AFib you have. There's this saying, AFib begets AFib.
Yeah.
The more disease the atrium also becomes. And so it's this sort of negative feedback loop.
And so there's different degrees of AFib?
There is different degrees, or at least we classify atrial fibrillation as paroxysmal, persistent, and permanent. And to use an analogy again, I think this helps with patients. When I am telling my patient about paroxysmal atrial fibrillation, I'm explaining it as a light switch that's just going on and off. You might be in atrial fibrillation for a couple of minutes, maybe a couple of hours, maybe even a couple of days, but you do go back into a normal sinus rhythm. Then we have persistent, which is like a light switch that is stuck on. You might be in persistent atrial fibrillation for upwards of 7 days. Okay, these patients are the ones that we're looking at. How are we going to medically manage with medications such as antiarrhythmics? We'll talk about that, procedures like ablations. Then you have the patient who has permanent atrial fibrillation. This patient usually presents, they've been in atrial fibrillation for years. They're in it chronically, they don't come out of it. That light switch is on and broken. These patients were less looking at maybe a procedure, more about addressing their symptoms and complications such as their risk of stroke. So that's how we classify atrial fibrillation. We know that globally, atrial fibrillation is affecting, right now, I think statistically 38 million people in the world have atrial fibrillation. To put that into a different perspective, that means that about 1 in 10 people over the age of 65 are diagnosed with atrial fibrillation, and even more so, 1 in 5 people over the age of 80 have atrial fibrillation. So we're seeing as the population is getting older, more atrial fibrillation is being identified. We're anticipating by 2050, which isn't that far away, these numbers are actually going to completely double. That has a lot to do with an aging population as well as hopefully better detection, which we're going to discuss.
Yeah, you nailed it. I mean, the number one risk factor for atrial fibrillation is age, for sure. And it also correlates with the risk of stroke. So maybe it's an important time to sort of delineate, why does atrial fibrillation predispose to stroke?
Yeah.
So remember we talked about this sort of inability of the top chambers of the atria to contract normally. And so they're not ejecting blood out the way they are supposed to. There's this little vestigial thing called the left atrial appendage. Just think of it like the appendix of your heart. Nobody really knows why it's there, but it tends to be a place where blood flow gets really sluggish. And that's where the preponderance of blood clots form. And if those blood clots break off and go to the brain, that's a stroke. So there's a number of ways we address that risk. If your risk on average is about 2% or greater per year for stroke, and that can be determined by, again, these risk factors, high blood pressure, diabetes, age over 65, 75, et cetera, then you qualify for a blood thinner. So there are a number of these drugs that are, we call oral anticoagulants, that are meant to reduce the risk of stroke, and they do so effectively, roughly reducing your risks maybe 60 to 80% per year, but not to zero, right? So there's some residual risk of stroke even with the blood thinner.
So what sort of symptoms are our patients feeling and experiencing that have atrial fibrillation, or what should they be looking for if they're wondering, is this something that I might have?
The symptoms are non-specific, but the most common symptom that I hear about is just the sensation of palpitations. So AFib has a tendency to make your heart race fast, and then it feels irregular, and people can feel both things, right? The irregularity is sort of this, instead of a nice metronome, even beat, it's that random drum beat that you talked about.
Yeah.
You can have, along with that, shortness of breath, sometimes chest discomfort, dizziness. So there's a whole host of potential symptoms. And then, roughly 30% of patients have zero symptoms at all. And what's really crazy, you've probably seen this in the ICUs, sometimes the first presentation of AFib is a stroke.
Yeah.
And patients come in, they have no idea they've had this rhythm problem, and unfortunately have suffered a stroke, and that's how the diagnosis is made.
I know in my clinic, I'm shocked, and you hit the statistic, 30% don't feel anything at all, which is just mind-blowing, because then you have these other patients that come in, they might have a skipped beat here and there. They don't think much of it, so they're not seeking any sort of attention. And then you have the patient that they feel at one time, and mind you, it's just a matter of everyone experiences it differently, but they're straight to the emergency room because the symptoms are so strong, so painful, so scary. It's really across the board. On that same note, I have a significant amount of patients who come in and it's no palpitations. It's more so about shortness of breath and fatigue, which we oftentimes don't correlate an electrical issue with those symptoms. We're thinking about heart failure and so on and so forth.
So it's the correlation that's key. From my standpoint, patients come in and again, they're telling you about things that are shortness of breath, for example, which could be 100 different things, right?
Yeah,
so then the job is, how do we correlate the rhythm with the symptoms? And so, it can be anything from an ECG to your Apple Watch. There's a whole host of wearables now. You can get these patches that you can wear for a couple of days. Yeah. I had palpitations a couple of years ago. I put a patch on, and I'm an expert, so I didn't read the instructions. And you may not know, but I'm a hairy guy. So I don't know if you remember the Steve Carell scene in 40-Year-Old Virgin where he gets waxed. So you put this patch on. You're supposed to shave and prep the area, which I did not do.
You should know this.
It was a very painful experience to get the patch off. So.
Hold on, wait. So you were like, I'm feeling some palpitations. I'm just going to go ahead.
He's probably in his office.
Big ass sticker right
I
on
wanted
my
to know, so
hairy
the
chest.
patch goes on.
Don't ask the nurse practitioner.
I got ahead of myself, and I got to tell you, I remember pulling that thing off like it was yesterday.
Oh, well,
But no AFib.
No
I didn't have
AFib. Okay.
AFib.
Next one. More important question. Did you
Yeah.
have AFib? Okay, good. Let's talk about that. Let's talk about kind of how we diagnose atrial fibrillation. So you're touching on monitors. And are you putting monitors on in your, okay, so.
Yeah, I will order them just because 5 to 10% of my practice is primary care stuff. So I have to do some of these things. So a monitor is just something that is going to monitor somebody's heartbeat, what kind of rhythm they're going to have, what it's supposed to look like on an EKG, which I think is what you were about to get into.
Yeah, there's a whole bunch of flavors of how we diagnose these things. You can get just the clip on the ECG leads in the clinic, ECG diagnosis. Sometimes you'll see it on telemetry on the monitor on patients who are in the hospital, and they just happen to have a diagnosis of atrial fibrillation. Sometimes folks will be coming in, seeing their physician before a surgery, getting cardiac clearance, for example. Yep. You make an incidental diagnosis of AFib.
Yeah, we see that
and then
a lot.
You must see all the time folks that come in with questionable Apple Watch readings, and then what do you do with that?
I mean, everyone is wearing an Apple Watch now. And at the beginning, they weren't that accurate, quite frankly. They're getting better. Yeah. And I think it is literally the forefront. I think they're going to get smarter and smarter. To be honest, it was a little frustrating because they would come in, everybody was coming in, I have AFib, my Apple Watch says so. And then we would put, a real monitor on and it wasn't atrial fibrillation, right? There's a lot of different types of arrhythmias that you can have that are not harmful to you. Right. And the Apple Watch has a little bit of a hard time distinguishing between these. But now I do have a significant amount of patients who come in, they have good tracings from their Apple Watch. It is atrial fibrillation, and they're getting diagnosed that way. There's another device called Cardia, which is really popular, where you're putting, your fingers on a pad that's essentially giving you an EKG, and it prints out a reasonable lead, and patients are bringing that in, and I think it's helpful. I think it is the future.
And you showed me the other day a stethoscope that'll give you an ECG
No,
reading
I'm using a stethoscope now. Yeah, so
Yeah.
it's a little high tech. I don't use it for all my patients in clinic, but it's a great stethoscope, and it produces a 12-lead EKG or a 6-lead EKG at least.
Wow.
And it
does a pretty good job.
Yeah.
So then patients come in, and if they have a clear diagnosis of AFib, there's really two things that we talk about in clinic. One is just how do we make you feel better, right?
Right.
And there's a whole host of things you can do, but it really just comes down to you can either use medication, what we call antiarrhythmic drugs, or you can do ablation or some combination of the two. Now, ablation is a minimally invasive procedure, so think about cardiac catheterization. It's a lot like that, where we tackle the areas of the heart responsible for atrial fibrillation. It tends to be primarily in the left atrium, and cauterize around the pulmonary veins, the 4 pulmonary veins that bring blood back from the heart back from the lungs into the heart. Historically, that's been done with either freezing energy or what we call radiofrequency energy, which literally cooks and makes a scar inside the heart. More recently, there's a technology called pulse field ablation, which is a really revolutionary technology that uses kind of high output electrical fields to cause small holes in the cell, so electroporation, and selectively target those tissues in the atrial myocardium that are responsible for AFib. And it eliminates the sort of risk of collateral damage that thermal ablation has, which has been a good step forward.
So when you're doing this procedure, you're essentially trying to stimulate atrial fibrillation to see where the focus is coming from, and then you isolate that area and go exactly to that area? Or how, when you're in there and you're actually performing this procedure, what is the process?
It's a great question. It depends a little bit on where the folks live in that spectrum of disease.
Yeah.
So for people who have the kind of AFib that comes and goes, the paroxysmal AFib, it's a pretty anatomically driven approach. So I'm going to get catheters up into the left heart, and I'm just going to cauterize around the pulmonary veins and generally get out of there.
Yeah.
There's no real diagnostics required.
Yeah.
More advanced disease, persistent atrial fibrillation patients often get more sort of tailored ablation in addition to the pulmonary vein isolation, we call it. And there's a whole host of things you can do, but you're right. You're sort of assessing where's there healthy tissue, where is there not, how large is the atrium, how dilated has it become over the years, and then you're sort of trying to target and tailor the ablation lesions beyond the pulmonary veins based on that patient's heart.
I remember when I was actually moonlighting in Kansas City, and I was a pulmonary critical care fellow, and I was working as a hospitalist, but I would run the ICU at night, right? Because that's what hospitalists did. And I remember the reason that I spent so much time studying AFib was one particular case. And it was a female who was maybe 60 some odd years old, who had had an ablation done for atrial fibrillation. And I was like, okay, this is interesting. And the reason the case was interesting was because she presented to the intensive care unit with an esophageal perforation. It was extremely sick. It was extremely ill. And I was like, what's going on? What's going on? And then I went back through the history, and I was like, wait, they had this AFib procedure. Does this have anything to do with it? Because I'm still learning, right? I mean, we're always still learning, but at that time, I was just a pulmonary critical care fellow. Not very common. What is it, like 0.6%?
I was going to say very uncommon.
Like very uncommon. But then when you look, and I was like, oh my gosh, ablation. All right, you can ablate. It was a thermal ablation.
Yeah.
And burn right through the atrium and got the esophagus, which is just right there. That's why anatomy is so important for you medical students. You get the esophagus, and then when you burn the tissue of the esophagus, every time you swallow, food goes right through the esophagus. You get a perforation, and people can get infected. People get extremely ill, and mortality is really high.
Yeah, it's like over 60%. It's really, really high.
Crazy. So I remember at that point, I was like, all right, I better learn atrial fibrillation, like backwards
what is this?
and forwards.
Yeah.
What do I need to do about it? And all these kind of things. So when you're telling me about this new procedure in which you're isolating single cells, it just seems like when you compare it to maybe thermal ablation, it's probably safer. Is that
very much so?
It's so much safer, and it's crazy because the field's evolved a lot. When I was in training, we would do 1, maybe 2 AFib ablations in a given lab in a day.
Yeah.
Right? We've gotten better even with thermal ablation in terms of safety and efficiency of the procedure.
Yeah.
And so now it's more like 1 in 10,000 patients will have a deadly esophageal fistula, but it's not zero. And if you talk about 38 million patients, and kind of as the number of AFib patients goes up, the number of procedures goes up, it's still a potential risk.
Yeah.
And so you're right, like the esophagus sits right behind where we're doing that ablation.
Yeah.
With this pulse field ablation technology, which has been out now for just a couple of years, there's no thermal effect. There's no collateral damage risk to the pulmonary veins, to the phrenic nerve, which runs right there and can cause breathing trouble if you paralyze the phrenic nerve, and as well to the esophagus. In fact, we historically have had to monitor the temperature the whole time we're doing an ablation to make sure the temperature doesn't go up. That's not even required with PFA. There's no temperature monitoring required.
That's interesting. That's super cool.
So it's a big step forward for safety.
So I guess my question would be, and again, this is going to get into more of a policy and insurance standpoint, because you're a CMO, Boston Scientific, so you must have the tools that are required to perform this procedure, I'm assuming. And my question is anyone who is getting this procedure done, so somebody sees an electrophysiologist and they say, oh, you know what, we need to ablate this tissue somehow. Are they getting that one done, or is it based?
It's a great question.
Do you know what I'm saying? Or is it based on plan? It just becomes that kind of a question. Like here we have this procedure that's super safe. It's way safer than this. Like what's
But which one are you going to
there?
get? Yeah.
It is a really good question. As we roll this technology out globally, it's not available everywhere all at once.
Yeah.
And so we're seeing this transition to this new technology, country by country around the world. And in the US, we got approval last year.
Yeah.
But to your point, like it's not everywhere. If it were my family member or me, I would request that technology, right? I would find somebody in the area that prioritizes using that technology from a safety standpoint. If it's an AFib ablation that you require, I think that it's pretty clear that the safety profile is superior with PFA.
And you had mentioned a couple of things so far. You had said, okay, one of the risks when you have atrial fibrillation is stroke, which is blood clot to the arteries of the brain, and then dead brain, and then you have some neurological complications. And then you had mentioned rhythm controlling the actual rhythm by ablating the tissue. But there's another element that we try to control as well, right? Which is the rate control, right? So I know, again, I'm an ICU doc,
I was
right?
like, this is your wheelhouse.
So this is like what we try to do, because when that heart rate is going really fast, what I think people don't really think about is the heart and lung work together, right? So we got a picture of the heart and lung behind us here. Is as that blood is pumping from the right heart to the lung, the blood cells travel into these balloons, and the rate at which they travel is the heart rate. But if the heart rate is really fast, like it can be in atrial fibrillation with the rapid ventricular response, the blood cells don't spend enough time in your balloon to oxygenate themselves. They don't get enough oxygen, so you get really, really short of breath, which is why rate control is one of the things as well, I'm sure, that you pay attention to.
Yeah, for sure. I mean, a normal heart rate is 60 to 100 beats a minute. AFib patients are often, 120s, 130s. And it can be the case that in addition to having a hard time controlling rhythm, getting the rate under control is difficult. In persistent atrial fibrillation, we often will cardiovert patients. So you sort of electrically, you've seen the TV shows where they defibrillate patients.
Yeah.
We do this in a controlled manner, but it's the same general setup, right? It's like defibrillator pads, you shock them back into normal rhythm. And, the folks that often don't feel like they have symptoms when they come in, this sort of 30%. Sometimes they find out, you know what, I did have symptoms all along and I feel much, much better now that you've cardioverted me. Sometimes that's even required in an ICU. Like if you have somebody who's really, their blood pressure's dropping, you probably cardiovert people all the time.
I do it all the time. Whenever somebody has AFib, so as your heart is pumping inefficiently, right? What happens is you get, that fibrillation, it doesn't pump as efficiently. And if somebody's really sick, and they have a condition, let's say, known as septic shock, where their blood pressure is really, really low due to an infection, then they get into atrial fibrillation. They can get into atrial fibrillation, and this heart is just pumping really fast, and their blood pressure drops because it's not efficiently pumping. And you got a decision to make as an ICU physician. At that time, you got to be like, all right, I'm going to try to use medicines to try to slow the heart rate down, or I'm going to try to use antiarrhythmics to try to get them back into a sinus rhythm. But really the most effective way in that point, whenever somebody has an unstable rhythm, is you shock them. You cardiovert them.
That's right. That's right.
But when you read about AFib, and you guys know this, like one of the things that in my head, I'm freaking out about it. But at the time when somebody's like literally dying in front of you, you don't really think about it too much. I worry about stroke because I'm like, man, I should be anticoagulating these people like right away. Every time I cardiovert in the ICU, I probably should be anticoagulating. What do you think about that? Anticoagulating meaning blood thinning. Yeah,
I mean, so outside of a life-threatening situation, we definitely think a lot about that, right?
Yeah.
And so who gets a blood thinner? Patients who are at elevated risk of stroke. And if your stroke risk is somewhere 2% per year or greater, there are ways to calculate this, right? We talk about CHADS VAS score.
Talk about the CHADS VAS score.
So, it's an acronym that stands for things like heart failure, hypertension, age over 75, diabetes, prior stroke, all add risk to having another stroke.
Yeah.
And so if your CHADS VAS score is in that 2 range, we offer anticoagulation.
Yeah.
And that takes the risk of stroke down by about 60 to 80%, substantially.
That's something that, again, as a pulmonary critical care doc, we see a lot of AFib, because when you look at what causes AFib, it's pulmonary and surgery. I guess those are the 2 most common causes, what I was reading about in the last review published in the New England Journal in 2021 or something. But so as that kind of physician, when I see it, I'm not scared of it, but at times I'm kind of like, am I doing enough?
Yeah.
Right? Because I got to sit there and think about, does this person need to be anticoagulating? And like by and large, like my patient population, they are 75.
Your patients probably definitely.
Yeah, they qualify, right?
They qualify.
Well, let me ask you this. So you're seeing a patient in pulmonary clinic, right? New diagnosis of atrial fibrillation.
Yeah.
What do you do with that patient?
So what do I do with that
patient? What
patient?
do you personally do with that patient?
All right.
Please
so listen.
Tell me.
I'm a little bit of a nerd. So I have a ultrasound in my office, and I will do an echo, and I will look for diastolic dysfunction.
All right.
I will look for reduced systolic function. I will look to see if the patient's currently in AFib, because you can see, on echocardiogram if they're in AFib. So I do that. In addition to doing that, depending on their CHAD score, I may actually start anticoagulation, call my buddy and be like, hey, this guy's got AFib. He was in the ICU. Now he's in my clinic. He hasn't had a chance to see a cardiologist yet. I'm going to put him on such and such anticoagulation. And can you get him in the next week or so?
Yeah, absolutely.
Right? That's generally what I do. But I also know that in my pulmonary practice, I might do a little bit more than most pulmonologists.
I'd say you do.
Right?
Yeah.
But I think, and again, I always get in this, like, it's not a tug of war, but with cardiologists, it's always like, is it the heart of the lung causing the shortness of breath, right? And so, like, is it AFib? And then,
Story
like,
of my
right.
life.
Or I'll see it, and I'm like, dude, he's got diastolic dysfunction, and he's got pulmonary edema.
It's just
like,
progress notes back and forth, battling.
right. I know the fluid is in the lung.
Yeah.
But, like, it might help if we control his rhythm a little bit. Anyway, so it's just...
We team tag it, right? That's what we team tag it.
Yeah, we got it. Yeah, exactly. And so it's like you think, like, I met you today, right? And so don't be surprised when I give you a call next week because I have a case like that in my office.
I love it. And look, if you're doing more and that's the more, then that's the right thing. I mean, when you see patients in EP clinic,
yeah,
and they're coming in as a new referral, right? You don't want folks to have waited to start that anticoagulant.
Oh, absolutely
right?
not.
I'm sure you would appreciate that approach.
Yeah, I love it when they come in and because they're just every minute that they're in atrial fibrillation, you're at risk of having a stroke. So yeah, I really appreciate it if they come in and they've already been anticoagulated.
I mean, for those of you who don't know, Savannah is an electrophysiology like nurse practitioner. So in my mind, when I was going through school, I was so afraid of cardiac electrophysiology. So
I
the
gravitated.
fact that you gravitated and are tackling it, accomplishing it, and like being successful, like I wonder what were the hardest parts of kind of learning that field? Like what did you have to do? Because you do a lot more than most nurse practitioners I know, like in terms of what you had to teach yourself.
It was a lot, but I think you know me. Yeah. I'm driven in that way. So when I started as a nurse, and we kind of talked about this, I was drawn to the heart, and you get drawn toward a field, right? So some people it's neurology, women's health, whatever it is. For me, it was the heart, and that was the best thing that could have ever happened to me. And my experience as a telemetry nurse, and then as an ICU nurse, then CCU. So we're doing open heart surgeries, CABG procedures. The love just grew and grew. And when I chose to become a nurse practitioner, I had a dear friend, Dr. Dukes, who I now work with, who's an electrophysiologist, took me under his wing. And when I went into the cath lab for the first time and watched these procedures taking place, it was just, it's mind blowing.
Yeah.
It's absolutely incredible. And I was like, this is a field I want to master. And when you translate that into patient care, and I have these patients coming in, like we're discussing, that have these symptoms that are just, again, they're sending them to the ER. They have these palpitations. This was a diagnosis not that long ago, right? That patients were presenting to their primary care provider with, they didn't know it was palpitations. Essentially, they were being diagnosed with like anxiety and being given anti-anxiety medications, right?
Yeah.
And we just didn't have the technology. So it's just this whole world that I think we're on the forefront of learning so much and helping so many people. And I want to be a part of it.
But all that required, like, I know the ICU nurses and the cardiac telemetry nurses, in my mind, when I'm in the hospital, all of the little educational events that you guys have to go through, the rhythm reading, the EKG reading, what the monitor is telling you, like all of that is difficult.
It either scares you and you're like, I'm going to look away, or someone's got to rise to the occasion. And I just became the person that understood it and ran with it.
Yeah. We had a guy at Iowa, and you probably have heard of this guy, Dr. Donald Brown. He was like the EKG king.
Guru.
So everybody from all over the world would come to do his EKG course.
Yeah.
Because he made it so simple, but he was so freaking smart. And he's the one that taught us the electrophysiology, but I was still like, nah, I'm not doing cardiology.
Yeah, it's a black box, and you either love the black box and you want to get in it and understand it, turn the lights on, or you don't.
You don't.
But I think it's funny because every institution has that as a Dr. Brown. And these guys can take, like, literally an ECG is just like it's some squiggly lines on a piece of paper.
Yeah.
And they can turn this into this 3D real life story.
Story.
Of what is happening electrically in 3 dimensions in your heart. And that art is getting lost a little bit, but it's amazing when somebody's really good at that. What's crazy now too is, so there's this group at Mayo Clinic that is using AI and machine learning to look at normal EKGs and tell you if you're going to have AFib in the next few years.
So I want to really dive into this, and we kind of circled. We were talking about the CHA2DS2-VASc score. So for our patients, when someone has atrial fibrillation, we're thinking about 2 things. We're thinking about your symptoms, and we're thinking about your risk of stroke. So it's like 2 pillars we have to tackle. The CHA2DS2-VASc score is a scoring system that we use to say yes or no whether or not we're going to put you on a blood thinner. And that can be we're talking 2 points to 3 points. And one of them, for example, is age. So if you're 64, you're not going to go on a blood thinner. But when you turn 65, suddenly the answer becomes yes. So the CHA2DS2-VASc score is something that we use, but there's a little bit of question behind it, right? And it's really the only thing we're using right now. And then now to your point, what is the future?
Yeah, it's not a perfect system. You're right about that. I mean, I think the future is this AI application to our everyday exposure, right? And that is our Apple Watch. That is, I mean, who knows what kind of biometric parameters, the next ring or whatever you're wearing will start to glean. People are developing ways to get chemical sensors just from your skin, right? And so I think, if you look at the publications from this group out of Mayo, not only can they predict AFib in patients with normal sinus rhythm today, but they can predict strokes. And, so you take millions of points of data and really nuance things that aren't really visible to the human eye. But if it's an image, machine learning does a really good job at predictive analytics.
Are these patients, what are the age in their data collection? You probably don't know the age, but I'm just thinking, like, how young can they do this? Are they taking 35-year-olds, or are they taking
good question.
50-year-olds? You know what I'm saying?
Yeah.
Because there's some aging process that's taking place, and are they taking into account certain comorbidities that these patients already have? That's my question, right? Is that yes, okay, it's a 50-year-old with normal sinus rhythm, but is it a 50-year-old with diabetes? And
how great if they build that database, and that's what we're able to do, though, right?
Yeah.
If we could take a normal EKG and put it through a system that's going to say this is your chance of having atrial fibrillation.
And it didn't stop there. So they can look at your QRS complex and predict your ejection fraction.
Oh, that would be
right.
We had this cardiologist, and I'm sure you had one at Hopkins. Dr. Kanu Chatterjee was at Iowa at the end of his career. He was one of the guys that worked with Swan and Gantz, in the early, he's like, he would be 110 or something right now. But he was on our cardiology service, my second and third year residency. And we were around with him. This dude would feel the chest, listen to the heart, and he would tell us what the ECG would show. And he would tell us what the patient's ejection fraction is. And he would say, ejection fraction, 35%. And he was right 99.9% of the time.
Wow.
It was like those kind of clinical skills, what people had to do back then to truly understand the physiology of what was happening inside someone's body. And now we've taken that human brain and we've applied it to AI to do something even greater.
Yeah.
And those old school cardiologists hate some of this new technology. So we had a guy. We had a Chatterjee at Hopkins. His name was Tom Trail, and he was a phenomenal teacher. And it was that bedside, palpable physiology. And he would do the complex congenital heart patients, and you really glean a lot just from how full is the volume of your pulse in your neck, and you spend 5 minutes describing the carotid pulse in every detail of the carotid pulse, right? And there is a beauty to that. Yeah. That is an art that I think we don't want to lose in medicine, but I think you also have to embrace the future, to your point.
Yeah, if we were talking earlier, I think some of that art is kind of getting lost a little bit, because what are people doing now? We're reading from our phones and watching television, or reading whatever articles on our phone, and not spending as much time at the bedside, looking at the patient. Where 70 years ago, what were they, that's what they had to be. Yeah. So they didn't have anything else to do. So they're just sitting there just studying these folks.
So let's transition. Our listeners have sent in some questions that we can all answer. Question number 1, Can atrial fibrillation go away on its own?
Yes, sometimes it can. So what's
Correct.
interesting is, again, think of AFib as a disease on a spectrum. Early in the disease process, it tends to be this paroxysmal atrial fibrillation. And sometimes
comes and goes,
where it
comes
comes and
and
goes.
goes,
Yeah,
yeah.
thank you. And sometimes there's a reason it comes, right? Your thyroid level's off. You're sick in some kind of way. You see this in the inpatient settings a lot. People
Also,
will have AFib.
caffeine, alcohol, big triggers.
For some people, and this is what, I like caffeine, I like alcohol. I tell patients anything in moderation. The fact of the matter is not everybody is sensitive to caffeine or to alcohol. So I think each patient has to sort of find, is this a trigger for me? And if so, obviously you want to avoid it.
In my clinic, though, and we've discussed this, when I see atrial fibrillation, whether it is for 1 minute or 5 minutes or an hour, I cannot unsee it. And so if a patient is identified, I've seen it on an EKG, they've had atrial fibrillation, my hope is that maybe, again, it was an isolated situation. They were in the ER and they had sepsis and we saw AFib and now they're better and hopefully we don't see it ever again. But the likelihood is that if they are in a situation comparable to that, whether it's 2, 5, 10 years down the line, they can see that atrial fibrillation again. So for me, it's always there. It's going to be on their chart. We're going to be looking for it.
That's 100% true. And there's a lot of debate in the field as to how much AFib do you need to see before you start to treat it aggressively with blood thinners. And
everybody
things.
is a little different.
Yeah, and there's not great consensus, but I think that's where you have to go back to your doctor, right? You have to get a professional who lives and breathes this every day and show them the data and kind of make a decision together.
Yeah.
And that professional, though, is a cardiologist.
Right.
I mean, that's who lives and breathes it every day, right?
Okay, next question. Are there natural remedies for managing atrial fibrillation? I like how we all do a little chuckle.
Listen.
I get asked this a lot, actually.
I don't know what the definition of natural remedy actually is. Like, what is the natural remedy? But
My
anyway,
answer to this is no.
right.
The answer is no.
I also would say no.
Yeah.
I would say no.
I think that there's things that we can focus on. For example, we know that high potassium levels, high magnesium levels can bring out atrial fibrillation. I have a significant amount of patients that are coming into my clinic and I say, what medications are you taking? And then the next question is, what supplements are you taking?
Yeah.
And they're taking magnesium, potassium because they read it somewhere. And the next question is, who's managing your levels? Well, I'm not having my levels managed. Okay, well, how do you not know that your potassium, magnesium are through the roof? Well, is that bad? Yes, it's bad. You know what I mean? This is conversations I have all the time.
Yeah.
So to that point, I think if you're a patient and you're using supplements are their own type of medication. Your primary care provider needs to know all the supplements that you're taking to ensure that there's no interaction and that you're not putting yourself at risk of having any type of arrhythmia.
Yeah. My other answer to that is not sexy or popular, but the fact is we talked about risk factors for AFib, right? And it's things like obesity and diabetes and high blood pressure. So managing your chronic comorbidities, exercising reduces your risk of AFib, likely reduces your burden, and increases the chance of success if you get an ablation. The management of those things appropriately increases the likelihood that you're going to stay out of AFib after that procedure.
I agree with that. Okay, our next question. Can I still have coffee or alcohol if I have atrial fibrillation? Asking for a friend.
Listen, I practiced in Kentucky for 10 years, so the answer is a little bourbon is okay. Or a little red wine, whatever your thing is.
And you touched on this.
Yeah,
so
no, I think things in moderation are good. And there are some patients who that is clearly a trigger, and then you got to use common sense and avoid your trigger. But they'll get to know their pattern. Sometimes there's no clear trigger, right?
Yeah, I do have patients that come in who, when we dive into it, I had 2 glasses of wine, and then I went into an atrial fibrillation attack. Yeah. Okay, well then the wine is not your friend. And then the other people can drink a bottle of wine, nothing happens.
I guess I'm kind of like, you shouldn't drink alcohol. Like if somebody comes into my clinic and I don't know, they're 70 years old and they have atrial fibrillation, I'm going to say like, you probably shouldn't drink alcohol. Because if they're telling me, I have a couple drinks every night, like they're having 8 drinks a night, right? And so I'm just like, no, you can't drink alcohol. And if I say no, you can't drink alcohol, they're probably going to drink like one.
You're just going to discount the number. Yeah,
Right.
That's fair.
I just kind of, it's just how I treat it.
I go, do you want my black and white answer as a provider? Then the answer is I'm not going to condone you drinking alcohol or smoking or sitting on the couch and not moving your body. Do you want me to be real with you?
Right.
Let's talk about that.
Yeah. I mean, alcohol.
You can see why I'm not seeing patients anymore, so I can say.
Right. I mean,
whatever.
alcohol is just one of those things. It's just it's so commonly accepted, and we do it. But like, there's a lot of danger with alcohol consumption, significant alcohol consumption, even maybe what we think is insignificant alcohol consumption.
No, I don't disagree with
question,
you.
no
Yeah, of course. Okay, let's move on. Atrial fibrillation always needs surgery, true or false?
It's false. And I don't even really like the term surgery.
I agree.
I mean, surgery implies something open and big incision. When we do a procedure for atrial fibrillation, an ablation procedure, it's a cardiac catheterization type procedure. So you got a big IV in the vein in the leg, catheters go up to the heart under x-ray guidance, and then we do all that work in the top left chamber of the heart, right? And so patients are generally put out to sleep, takes about an hour, and then they tend to go home either same day or next day. But it's for symptom relief. And so if you're in that group of patients that has occasional AFib and you don't feel it, right? You don't need a procedure of any kind necessarily. For folks where it's really burdening them and it's impacting their quality of life, that's when we really talk about, do you need an ablation? And if you look at the data, ablation is clearly superior to these antiarrhythmic medications, which have their own, potential side effects. So, so much so that the guidelines this year were updated, and the newest iteration of guidelines say ablation for paroxysmal AFib patients is first-line therapy.
Oh, wow. That's interesting.
Yeah.
And one of the medicines that's commonly used is amiodarone. But we say don't use it more than 6 months now. I mean, that's kind of a big thing, isn't it?
Yeah, amiodarone is a very strong antiarrhythmic medication that we do use quite regularly. Usually, at least within my office, we're using it post-ablation for a period of time, simply because after the ablation, the heart has some inflammation. We want that inflammation to heal. The heart wants to go back into that arrhythmia for upwards of a month. And so we use an antiarrhythmic medication to keep things under control, with the thought that when I see that patient for follow-up and their EKG looks beautiful, they're in normal sinus rhythm, we take that drug away. So amiodarone does have high risk of toxicity.
Oh, yeah.
Preferably, I like my patients to be on it 3 months, 6 months max. I know there's still people out there that keep their patients on amiodarone endlessly for years.
Yeah, it's not great practice.
Not great practice.
And it can not just affect the rhythm, but it can negatively affect your thyroid, your lungs, right? A whole host of toxic sort of end organ effects. And you really have to get those things monitored. So if you are staying on long-term amiodarone, there are recommendations for annual sort of lung function tests, chest x-rays, thyroid studies. It's a whole host of things that have to be monitored.
To that point, though, there are other antiarrhythmic drugs that we can utilize that are not as strong or risk of toxicity as amiodarone. So if we have patients who come who we tell them about ablation and they're, that's not the route I want to take, there are other options that we can manage their symptoms.
So I guess my question for you guys would be, as a pulm crit doc, and again, I was in the hospital last night, but if somebody has AFib with RVR on the floor, 99 times out of 100, I'm giving them an amiodarone bolus with a drip for at least 24 hours. Should I be doing something else?
My answer is that's fine in the inpatient setting.
Yeah.
With a plan to transition them to some other,
Agent.
some other therapy, right? Or evaluation for potential procedure.
So if as an inpatient, if I wanted to transition them and say, they still need some kind of an antiarrhythmic, what should I use? Like, what should I transition them to in the inpatient setting?
I like flecainide. I also really like dofetilide, quite frankly, but that's a drug that we do have to start in the hospital, mostly because we want to monitor them on an EKG for a few days. back to your point, if I have a patient who comes into clinic and they present with atrial fibrillation with RVR, which essentially means that you're in atrial fibrillation, but your heart rate's going really, really fast. So maybe you're going 120, 130, 140 beats per minute, and that's just a lot of stress on the heart. We don't want your heart to stay going that fast. I send them straight for cardioversion.
Yeah.
Once again, because amiodarone's just not the drug I want to see them have to stay on. So I'll have that patient walk across the street, go over to the hospital, get cardioverted, because if we can shock them and get them back into normal sinus rhythm, perhaps we never even have to discuss putting them on an antiarrhythmic. And then it's just a matter of monitoring them. And sometimes patients have to get cardioverted multiple times. Or we do a course of amiodarone for a month or so, see if that works. And then if it does, but we don't want to keep utilizing that specific drug, we transition them to a different antiarrhythmic for what could be indefinitely or until we discuss possible ablation.
I think is one other important piece for patients to understand, which is, again, it comes back to your two pillars. There's the rhythm control, get you feeling better pillar, and then there's the stroke prevention blood thinner pillar, right? So all of those things, whether it's antiarrhythmic medications, cardioversion, ablation, that are meant to get rid of AFib, fall into that rhythm control pillar.
Correct.
It does not negate the need for a blood thinner, right? So you're still making an independent assessment. Oftentimes when we cardiovert somebody, right, we're doing a transesophageal echo. So we're putting an ultrasound probe down your esophagus because the esophagus sits right up against that left atrium, and we're looking for blood clots. And if we see a blood clot as cardiologists, we don't cardiovert you.
Right.
Because we don't want the heart to restart with normal beating, right? And that causes the blood clot to embolize somewhere bad like your brain.
Yeah.
So then you get a course of blood thinners generally, and then a relook with another echo down the road.
Yeah, good point. Okay, we have a few more questions. Can you have any irregular heartbeats and be fine, or is any irregular heartbeat considered atrial fibrillation? So I think I see where they're going with this question.
Yeah, so there are a lot of reasons for the heart to feel irregular, right? You can have premature beats just come every so often from the top chamber. You can have similar premature beats that just come every so often from the bottom chamber.
Which are completely benign, non-harmful.
Very often they're completely benign. And so, but you might feel them, and they're annoying, and they may or may not be treatable with procedures or medications. So I think the short answer is, if you feel something that is irregular and you're concerned about it, get it evaluated.
Yeah.
And whether it's with a patch, make sure you shave your chest first, or something implantable or wearable, whatever the case may be. The goal there is to try to correlate your symptoms with the rhythm that we see.
And one of the things I always tell patients in that scenario is, I'm like, listen, if you feel that in your chest and you're lightheaded, that's a problem. That means you need a medical attention like right away.
Agreed.
So if you're getting dizzy or you're getting lightheaded and you feel a palpation or palpitation, then that's something where you need to go to the hospital and just be looked at right away.
Yeah.
That's fair.
Okay, we have one last question. You talk about the positives of blood thinners, but what are some of the concerns? And this is a great question. This is a conversation I have with my patients all the time as well.
Yeah, you guys see the concerns, I'm sure, every day in the hospital. I mean, bleeding, right?
It's bleeding.
And you can bleed a lot of places. Most worrisome is bleeding in the brain.
Yeah.
So there's no free lunch with blood thinners. They're great drugs, but obviously any blood thinner increases the risk of systemic bleeding. And they're not perfect at preventing stroke, right? So there's still 20-30% residual risk of stroke depending on the blood thinner in the patient.
Right.
And so sometimes, you may need other therapies or a combination of therapies to really bring down your stroke rate effectively.
And so a lot of times in these cardiac patients, not only are they on blood thinners because of atrial fibrillation, but they're also on antiplatelet agents because they have a history of coronary artery disease and they had a stent placed or something like that in the artery to keep the artery open. So as an ICU physician, I see brain bleeds all the time. I see, retroperitoneal hematomas, which is blood kind of in your stomach area. I see that frequently. But just because I see it frequently as an ICU physician doesn't mean that it's common in society, because these things are uncommon and they are associated risks as a result of being on an agent that tells your blood not to coagulate. And so we have to pay attention to these things, recognize the risk, understand the risk, make sure that you know the signs of something like this happening to you. That's an education standpoint that your physician needs to provide you. But I think at the same time, we understand how beneficial these types of medications are to patients that have these issues. Dr. Sutton, you have spent a lot of time with us today discussing atrial fibrillation, talking about therapies, talking about risk factors, talking about causes. But out there's a lot of patients out there, there's a lot of people out there that have listened to this. What are the takeaways? What are the top 3 things, say, that you want to give the viewers out there?
Well, I appreciate the chance to talk about AFib. It's something that's, that, like I said, we live and breathe every day. It's the most common arrhythmia in the world, right? So in terms of heart rhythm abnormalities, this is the most common. As you get older, it becomes more likely, right? So retirement age, it's a pretty substantial risk. By the time you're 80, what did we say, 1 in 5 patients has atrial fibrillation. It increases your risk of stroke by about 5-fold as compared to patients that don't have atrial fibrillation. And then you get into these stroke prevention strategies. And we can do something about it. If you have symptoms that you're worried about and you get diagnosed with atrial fibrillation, particularly today in a world where we have this pulse field ablation option and a better safety profile, ablation is a really good thing to consider and discuss with your physician.
So we like to end each of our episodes with a positive pulse. And today, since we have Dr. Sutton with us, I think this would be a wonderful opportunity for him to share a personal story in regards to how atrial fibrillation and specifically Watchman has affected your life.
Yeah, so thanks, Savannah. When I was a resident, I got a phone call from my mother, and she was frantic. And she said, "Your dad's not making any sense. He's seeing strange colors, and the ambulance is on the way." And it turned out my dad is somebody who had coronary disease and heart failure and diabetes. He was not, he had a lot of comorbidities, but also long-standing persistent atrial fibrillation, and was on warfarin at the time, which is an old school blood thinner. Folks in the audience may know it as kind of rat poison historically. It's literally what it was. And it was a drug that required you to frequently dose adjust and monitor your levels, right? So, that can be challenging. And he had a brain bleed and subsequently passed away from an intracranial hemorrhage. And so fast forward then, 15 years in my role with Boston Scientific, I oversee a part of our business called the Watchman device. And so Watchman it's a device that's placed endovascularly in that area where these blood clots come from when you have atrial fibrillation, this left atrial appendage area. So it's literally a plug that sits at the opening of the appendage and prevents blood clots from going wherever, importantly to the brain. So it's an alternative to blood thinners for patients who are seeking something other than lifelong anticoagulation. And so it's just an amazing sort of full circle journey for me in my life to think about a therapy which wasn't available at the time he passed away, unfortunately, but could have potentially saved his life.
Wow. Wow.
I'm seeing a lot of patients in clinic that are leaning toward getting off of their blood thinner, and they're requesting to have the Watchman put in. And it was at one point, we were only putting a Watchman in for patients who essentially were on the blood thinner but had had a major bleed, right? They already had it. They took a big fall, they had a head bleed, and now we're looking, how do we get this patient who cannot be on a blood thinner off of it? And we were looking at the Watchman. Things have changed recently with insurance, and it's much easier now for patients to have access to this as an option. I have patients coming in all the time who are covered. You see that patient walking around, they're just covered in bruises, their arms, their legs. And that's really bothersome for them. They hit a wall, they look at a wall, and they get a cut, right? So the Watchman is changing things drastically right now, and I think in such a great way, because I don't really want to see my patients on blood thinners if they don't have to be, just because of the risk. And Watchman, we're putting these in. It's a very straightforward procedure. There is a time period that they need to remain on their blood thinner, but then they're off of their blood thinner and they're staying on a baby aspirin for life.
Yeah, so the phrase we like to say is kind of one time for a lifetime. And it's this idea that you have a one-time procedure. In our clinical trials, the risks associated with the procedure are 0.5%, right? So 0.5% risk of adverse event within the first 7 days after the procedure. And then presumably you're off your blood thinner for the rest of your life. So it's a really nice option in the right patient. And again, if you have atrial fibrillation, you're having difficulty either tolerating the blood thinner, or you just want to look at an alternative to a lifelong blood thinner, a reasonable thing to discuss with your cardiologist.
And the Watchman procedure plugs the appendage, or what is it plugging? The appendage?
Yeah, the appendage.
The appendage.
So the appendage is like a kind of a windsock shaped part coming off the left atrium. This literally is a nitinol frame that comes out of a catheter, expands sort of like a circle, right? And has a fabric that sits in and plugs the appendage, and then heals over with normal endothelium. And so it becomes a normal part of your heart, and that whole appendage then is excluded from the rest of the atrium.
And the reduction of stroke risk with that procedure in comparison to blood thinners is comparable.
It's comparable. It's a great question, and we just reported out in the New England Journal a clinical trial called the OPTION trial. So this is specifically in patients who are undergoing AFib ablation. They were randomized 1-to-1 with a watchman versus long-term anticoagulation, then followed for 3 years.
Wow.
And the stroke rates were low in both groups, but essentially identical, 1.2, 1.3% at 3 years. And so in head-to-head randomized trial,
it's amazing.
Comparable.
That's amazing. And these were just patients in general. It wasn't patients who had a previous history of bleeding or anything like that. They were just like...
In fact, so these were ablation patients in that trial specifically, and they had to be able to tolerate long-term anticoagulation because there was a 50% chance they were randomized to that arm. So they couldn't be bleeders.
Right.
And then half of them continued anticoagulation, half of them got the watchman. We're also running a trial that's very similar in sort of scope in an all-comers kind of patient population. So you don't have to be an ablation patient in this trial. It's called Champion AF, and that reads out in the first half of 2026. And we'll see exactly how does this appendage closure device compare to anticoagulation over a 3-year period of time.
Wow. That's amazing stuff. Actually.
So many new things coming for the world of atrial fibrillation. Just arrhythmias in general. It's exciting. Yeah.
As always, please visit your primary care physician for any specific questions that pertain to your own medical health. We talk a lot about medical concepts because we want you to be educated, but we also know that relationship with your primary care physician or specialist is much more important than your relationship with what we're saying. So please visit them, talk to them about your specific health. We really appreciate all of you for tuning in. We want you guys to follow at the Health Exchange Podcast on Instagram. Please also subscribe our video pod on YouTube, The Health Exchange, as well as all audio capabilities. We're on Apple Podcasts, we're on Spotify as well. We really appreciate you guys tuning in. We will see you next time. And always remember, an episode drops every Thursday at 6 a.m. Pacific, 9 a.m. Eastern Time. Take care, and we'll see you next time.